Good afternoon, good evening. I'm Keegan Guidolin from the University of Toronto. Thanks for the opportunity to present our research on postoperative outcomes in patients with locally advanced colon cancer, a comparison of operative approaches. Our disclosures are listed here. So it's well established that compared with an open approach, minimally invasive colectomy is associated with decreased complications like wound infection and a decreased length of stay. However, previous literature has suggested that these benefits are lost if you convert from an MIS to an open approach. As a result of this, surgeons were advised to use an MIS approach only for those patients who were unlikely to require conversion. And this in turn resulted in surgeons avoiding MIS approaches in patients with locally advanced colon cancers, which at the time had conversion rates of up to 50%. More recent data has suggested that as surgeons' skill with laparoscopic colectomy has improved, both the conversion rates and complication rates have decreased for locally advanced colon cancers. And so our objectives with this study were to compare the perioperative outcomes associated with different operative approaches in locally advanced colon cancer, and more specifically, to determine whether conversion from an MIS to an open approach independently confers a significant risk of morbidity in modern populations with locally advanced colon cancer. We conducted a retrospective cohort study using the NSQIP database, looking at all patients undergoing colectomy for T4A and N2 colon cancer from 2014 to 2018. Our primary outcome was any complication within 30 days, and secondary outcome was 30-day mortality. We compared three groups, those who underwent MIS, those who underwent planned to open, and those who had a converted surgery, so an MIS converted to open. We did a uni and multivariable analysis by logistic regression and Cox proportional hazards regression. Ultimately, we evaluated 1,286 patients. The conversion rate was 10%, and the only significant demographic difference between the groups was that those undergoing planned open resections had a higher ASA class. What we found on univariable analysis was that conversion was associated with a higher rate of post-op complications and of mortality as compared to both MIS and open groups. And this is consistent with what we'd expect from the historical literature. But when we did a multivariable analysis and adjusted for other relevant factors like age, ASA class, sepsis status, and M stage, there was no difference between MIS and converted cohorts. And despite this, patients undergoing a planned open operation had a greater risk of complications than those who were converted, which is in contrast to what we've seen historically. We also found that approach was not associated with mortality. And so in conclusion, in contrast to previous research, conversion does not independently increase the risk of postoperative complications in those with locally advanced colon cancer, and therefore, where expertise is available, an MIS approach may be preferable to an open approach for these patients. Thank you.